is the okay. So this meeting should be a very extensive course for today. So, but to complete this course, I need to have about half of the day. Okay, half of the day to present about neonatal jaundice. Okay, we we wait some of our colleague to come in, enter our. Okay, first of all, what is neonatal jaundice in this class? Actually, I'm taking class for neonatal jaundice, I think 3 years back. This one actually I'm using the same slides. Okay, I hope it's benefit you all with this training. This training actually need about half of the day, but we'll divide this training to 3 parts lah. Okay, but today is the first part. Uh, okay, so what is neonatal jaundice? Okay, take your coffee. I dah makan minum coffee, so many coffee, so much coffee already. Tak boleh tahan, dah mengantuk gila. Okay, so what is jaundice? Jaundice is actually yellowish discoloration of skin, skin, sclera, and mucous membrane. Males, which is accumulation of bilirubin. Okay, when we're talking about jaundice, it's all about hyperbilirubinemia. Hyperbilirubinemia means this increment of bilirubin production in blood. But to manifest in humans, you need at least 5 milligram per deciliter. So jaundice is you can divide it into unconjugated and conjugated bilirubinemia. They actually sometimes they will use indirect bilirubin. Indirect bilirubin means unconjugated bilirubinemia. So direct is conjugated. For neonatal jaundice is we will emphasize in indirect bilirubin, which is unconjugated. Okay, one of the most common condition in A2 especially. When you are in A2, you will see a lot of cases, but certain cases in A4, we also see few cases with neonatal jaundice. Okay, so it's normal, okay, to have a transient rise in serum bilirubin, but as I told you, it's only visualized in 75%, which is when the bilirubin more than 5 milligram per deciliter. Okay, when the patient is more than 5 milligram per deciliter, you can see the patient having neonatal jaundice. So doesn't mean the patient need phototherapy, but after this, I will actually enlighten or teach you all regarding how you want to determine the level of neonatal jaundice with visualization. Okay, by visualize, when you examine the patient, then you can see the level of jaundice, and you can determine the you can actually some sort guess, okay, the level of the bilirubin. Is actually more common in Asian baby. So we are Asian, we are not Europe, we are not dealing with Australian babies. Then you can see this one is actually this is common. Is it common? When we talk about physiological jaundice, everyone like to see what is new physiological jaundice, what is pathological jaundice. Okay, Physiological jaundice is very easy. It's actually the same. So you can see the increment of our production of the bilirubin is excessive during that time. There's three causes cause this. Okay, I didn't ask about this because I think this one is too deep for houseman to know. But I used to ask this question before because I'm expected you all to know this because I'm teaching all the housemen. I think 3 years back. This one is such a very crucial and important information. Okay, but I already teach you today, then you need to remember the physiological jaundice is caused by three lah. Okay, number one is the higher hemoglobin content. If you can see our patient, especially neonates, you can see the hemoglobin is 20, 18 at least, kan? So that's caused the higher percentage of our babies to get neonatal jaundice. Okay. At the same time, we have a shorter red blood cell lifespan. Okay, shorter lives is about 90 to 120 days only. So when you have this problem, you can have an fast turnover. Okay, when there has a fast turnover, you can have excessive production. Okay, at the same time, you expected poor bilirubin clearance because of liver immaturity. Okay, if you that's the cause of physiological jaundice. It will appear at 2 to 4 days of life and resolve after 1 to 2 weeks in term baby and 3 weeks in preterm baby. So I like to emphasize this, okay? Adik-adikku, if you have a A2 houseman, please ask them to join this class because this class very good, okay, for you to learn, to learn. Usually is not associated with underlying disease. What that mean by underlying disease? Underlying disease means they have okay, they have no, it's not related with D6PD deficiency, EBO incompatibility. Okay, most of the time. So you need to have a good certain things you need to have a you need to have information such as mother blood group, G6PD deficiency, or any other related disease which is can rule out this physiological jaundice. Okay, most of the time when patient go to I'm seeing patient in A2. So patient day 3 of life, mother is B positive. Most of you will give the diagnosis neonatal jaundice secondary to uh, secondary to mother apa namanya sorry bagi diagnosis ni poor apa inadequate feeding. Okay, inadequate feeding ni difficult to see, you know, because when you have a 10% weight loss, as I told you yesterday, this actually is a normal thing. So it's best for you to label the baby as physiological, physiological jaundice. So I think better for you to have a good understanding about physiological jaundice. If patient have no risk, why not physiological jaundice? Patient day 5 of life, patient have O positive, but TSB is just below intensive. You can actually say this one NNJ secondary to physiological jaundice. All day 4 of life, patient O positive, but you have a rated count. Rated count is only 3, less than 5. You can say this one is exaggerated physiological jaundice. Okay. So this one such a crucial information. Okay, it's appear after 24 hours. It's not less than 24 hours because if more than 24 hours, most of the less than 24 hours, most of the time is pathological jaundice. That's why we need to investigate. Okay, we need to investigate, especially when The bilirubin is more than certain level in less than 24 hours of life. Okay, maximum intensity. Most of the time, I will see this physiological jaundice. There's some characteristic about physiological jaundice. It's more than day 3. It's day 3 and above, especially when the baby is O positive. Is A positive, B positive. Most of the time, I also say this physiological jaundice because they don't have any risk factors. Most of the time, the level is less than 15, which is less than intensive phototherapy, but clinically not detected after 14 days. This one is a character, okay, of physiological, okay. Character of Bharati. Bharati is a very apa namanya, very suka gelak ketawa. Dia sangat suka Dr. Nisa. Macam tu lah contoh. Contoh berarti mesti marah saya. So this one is character lah. So tak boleh lah cakap physiological jaundice when the baby is 20 hours of life. Mestilah more than 24 hours of life than less than 14 days of life, because more than 14 days of life is actually uh, is a prolonged jaundice already. Okay, we talk something very molecular today. Molecular today, what do you mean by molecular? You can see actually in this particular training, you can have a bilirubin physiology and metabolism. So it's very extensive course, but I will give after 40 minutes, I berhenti lah. Okay, so we'll continue either tomorrow or the next day lah. Okay, bilirubin physiology and metabolism, which is bilirubin is derived from the breakdown heme, which is protein in hemoglobin and myoglobin. Okay, heme and hemoglobin and myoglobin, which is every 1 gram. Okay, every 1 gram of hemoglobin result in production in 34 milligram in bilirubin, which is production in bilirubin in normal baby is 6 to 10 milligram per kg per day. Okay, so it's something that common, okay, common to have this apa namanya jaundice. Okay, so hemoglobin, they have heme and globin. You use they have heme oxygenase, which is convert to biliverdin, CO and ferrum. So then they actually other source. Okay, they will go to the uh, bind to unconjugated bilirubin, which bind to S protein. This S protein actually go inside the liver by protein we call Y protein, or we call it ligandin. Okay, ligandin actually make is water soluble, then it's go to the excreted to by canaliculi. Canaliculi, then they will excreted to the stool. That's why when the patient have biliary atresia, you can have the pale stool, okay, because there's a problem in the excretion to the bile canaliculi, okay. So this one actually then reabsorption to the intrahepatic circulation, okay, by beta glucuronidase. Okay, so I will ask this question on Sunday. Okay, if you didn't, I want you to draw and answer my question. Okay, so this one is bilirubin turnover in units. Okay, what is pathophysiology of physiological jaundice? Okay, this one such a very crucial also. If you want to talk about pathophysiology of physiological jaundice, as I told you, the lifespan about 90 to 120 days. Okay, in the full-term baby, it increase in erythrocyte volume, increase in RBC or hemoglobin itself, increase in bilirubin load on the hepatic cell, defective uptake in the plasma into liver cell, which is decrease in the transport ligandin, defective conjugation, which is low activity of enzyme gluconosyl transferase, okay, which is convert unconjugated to conjugated. Okay, at the same time, you can see the low conversion of bilirubin to urobilinogen. Urobilinogen actually excreted to the intestinal flora, which is go to your enterohepatic circulation. Okay. Then they will actually apa masalah dia? Because of this difficulty, they will end up they will end up go back to intrahepatic circulation. Okay, decrease in excretion. Okay, that's why certain they have understanding when the baby have a good stool output. Okay, they will less jaundice, less jaundice. Okay, okay, this one I suggest I see. That's I told you yes, that's now. Okay, physiological jaundice is benign, benign. When we're talking about physiological jaundice, yeah, don't need to be worried about physiological jaundice. Certain hospital say, doctor, you not seems not worried lah, doctor. Physiological is something then you need to worry. If I'm worried, most of the time it's less than 24 hours, or patient have high risk, less than 72 hours only. Because when you have a physiological jaundice, most of the time, when you detect it early, when you give a good phototherapy, they will improve by our treatment. Okay, but in certain patient, when you cannot detect the high bilirubin in the baby, they can lead to bilirubin encephalopathy. Okay, I think I see 2 to 3 patients. Okay, late detection. Okay, mother refused for exchange transfusion. Then it's crucial for you to detect the patient pathological jaundice and patient with high risk. That's why I'm asking question about severe hyperbilirubinemia. Azira, I'm asking yesterday, she can answer quite okay, quite well. Then that's why I'm passing Azira yesterday. Okay, Azira, congratulations yesterday dah pass assessment. Okay, this one yang you need to answer. Okay, semalam Azira dapatlah G6PD, mother group O, CFC dia dapatlah. Tapi dia lupa prematurity. I suruh dia buat apa? I suruh dia pergi tengok dekat dalam our prem site. Oh, prematurity. Okay, prematurity is a risk. Okay, low birth weight and jaundice less than 24 hours. G6PD, that's why we need to trace our G6PD. Other risk factor is excessive weight loss. Exclusive breastfeeding also is a risk factor. Cephalohematoma, IBM, and family history of severe NNJ. NNJ and herbs, there's no quality evidence. Okay, when you're asking about NNJ and herbs, did you take traditional medication? Dia kata, actually I took traditional medication, but it's actually no quality evidence. Okay, you can ask, but it's no quality evidence. In Malaysia, we found out actually less than 50% of mother has good knowledge. That's a problem. So housemen also have problem. Why we need to bother about the mother? Okay, housemen, I'm asking about jaundice also, they didn't know. 50% of our housemen didn't know the jaundice. No lah, teruk sangat 50%. I think about it, 90% lah. More our housemen know about the jaundice. They have know in and out lah. Barati kan. Memang knows everything about the neonatal jaundice. Neonatal jaundice is something that you need to, although it's important, but everyone is didn't aware that putting neonatal jaundice baby under the sun could be cause dehydration and worsen the jaundice. Adik-adik, is something that you need to educate your siblings, your relatives, your friends, okay, which is you need to make their understanding better by not putting the baby outside, okay, under the sun, which is it can cause dehydration, okay, it can cause dehydration. Okay, this one such a very good. Okay, ni saya tak pernah ajar. Okay, this one you punya pneumonia, jaundice. Okay, jaundice less than 24 hours. A siblings with neonatal jaundice, you unrecognized hemolysis and non-optimal suckling nursing. D deficiency of this 6PD. I infection. C cephalohematoma. Then E is Asian. Okay, pathological jaundice is a very crucial for you to understand. And on and off, I'm asking this question because I think pathological jaundice you need to remember. Okay, now, pathological jaundice is something that you need to understand because it's something that very crucial. Okay, jaundice, which is considered pathological jaundice when the duration is less than 24 hours. In certain housemen, they understand it's more than 14 days in term baby, 21 days in preterm. It's okay. It's good understanding, okay? But you need to remember, okay? When you say the pathological jaundice in prolonged jaundice, you need to think about conjugated and unconjugated. Okay, that's a thing you need to remember. Okay, causes of pathological jaundice is most common is ABO, incompatibility, and rhesus incompatibility and minor group. Okay, we have a few groups, Kelly, other things, other minor group also, and Kelly, Duffy, which is also can cause this pathological jaundice and hemolysis. You can see hemolysis 6, 7, but it's not A block. Blood mother group O, there's no rhesus, then you need to rule out incompatibility of minor group. Okay, infections such as GBS, mother have virus, COVID is not, for now, it's not related with jaundice yet. We don't have any good evidence. Okay, membrane defects such as spherocytosis, elliptocytosis, and stomatocytosis. Red blood cell enzyme defect. Dr. Anissa suka tanya soalan ni. Membrane defect such as spherocytosis, elliptocytosis, red blood cell enzyme such as SPD deficiency, pyruvate kinase deficiency, or polycythemia. Okay, polycythemia we commonly seen in IDM and prime babies. Okay, day one is pathological, physiological from day 2 to day 14, and prolonged jaundice, which is you also call it pathological. Okay, danger in hyperbilirubinemia if left and untreated can cause acute or chronic bilirubin encephalopathy, which is the sign symptom is refuse to feed, excessive crying, you can see very bad until cause convulsion, retocolitis, and epistotonis. Okay, these symptom and features you need to recognize. Okay, I think I'm seeing to 1 to 2 patient only having this epistotonis and convulsion. Okay, because of very late diagnosis or late detection of hyperbilirubinemia. Okay, so when we dealing with hyperbilirubinemia, we need to houseman, what you need to know, you need to determine this patient have encephalopathy or not. Okay, you have a moro is incomplete, lethargic, poor feeding. At the same time, we can see for preterm, you can have apneic episode. Infancy, they can have chorioathetoid, dental dysplasia, deafness, paralysis of outward gaze, intellectual retardation, hearing loss, learning disability. Okay, risk factor for developing severe jaundice in babies need to be identified during antenatal and postnatal period. for you to give an information and education to parents. Okay, I think in this Zoom meeting itself, in not houseman only, I can see a few of my ex-houseman, which is a medical officer. Okay, you need to educate. Okay, please kindly educate. Educate your parents. Okay, because when they have a patient, a baby with neonatal jaundice, especially very high risk, okay, they can ready and prepare their mind. Okay, home monitoring is such a very crucial for community healthcare providers to have a postnatal period monitoring, which is day 1, 2, 3, 4, 6, 8, 10, and 20. Okay, certain doctors, especially which is just get delivered at home, they are very agitated because KK will do a frequent screening. Okay, frequent screening. All babies discharged less than 48 hours should be screened within 24 hours. But in our hospital setting, and our current situation in coronavirus, we will give 2 to 3 days lah, 2 to 3 days. Because most of the time, if the baby is discharged with phototherapy, most of the time is below than phototherapy. Okay. Okay, thank you. This one actually for the first slide saja. Ada lagi banyak slide sebenarnya. We have another 10 minutes. Okay. Okay, I will continue with the second topics today. Okay. Okay, second topic actually such I think tak banyak sangat. I think this topic. Okay, training of core trainers, okay, and the detection of assessment in severity. Okay, this one I think we have about 10 slides. Okay, bear with me. Okay, stay tuned. Okay, for 10 minutes, another more 10 minutes, you can go to get your grab food. Grab food or any food you can take lah. Okay, to compare the different method to determine the bilirubin level. Okay, the aim of these topics is actually for you to early detection. And certain junior doctors and they have problem in detection in jaundice, which is it's okay. It's okay. Okay, for you to determine this one jaundice, but after you take TSB is below photo, it's okay, no problem, because the gold standard of determine the level of bilirubin is by blood serum. Blood serum. Okay. Visual assessment. Okay. This one Dr. Nisa always asking. Okay. Meeting end already. Okay. Sekejap. Meeting already end. Okay. Another 10 minutes. Visual assessment is actually not the best, but as a medical personnel, you need to remember this one is our great tools. Okay, what you need to do, you need to perform by blanching the skin with slight finger pressure and noting the underlying color of the skin. Okay, so kadang-kadang problem with our doctors, they didn't do this. Okay, you can see kat bawah ni, didn't do this. Okay, jaundice usually, as I told you during the last topic, we can we visualize when the serum bilirubin more than 85 mole per liter. Okay, which is you can assess head to toe as the level of bilirubin rises. Okay, I want to share you one of my I get a referral. I get a referral from one of the housemen in ONG. Okay, what they refer me a jaundice doctor. We have a jaundice patient doctor. 40 hours of flying term baby, blah 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 blah. We noted jaundice from the toes to the abdomen. So for you to determine the jaundice, You need to make sure you understand. Okay, it's from head to toes, bukan toes to the head. Okay, the level is from toes to the head to toes. You can do. Jangan buat kelakar. Okay, when you refer me, you said, okay, doctor, the level is from toes to the abdomen. Okay, it's not lah. Okay, it's not right. Okay, it's not right. Okay, visual assessment is not reliable, as I told you, but it's good for you to know about Kramer's rule. Okay, Vinisha kan, Dr. Anissa tanya kan about Kramer's rule. This one is Kramer's rule. Very easy. Head to neck is 5. Upper trunk is 10, lower trunk, okay, lower tongue to thigh below umbilicus is 15, arm and lower limb is 20, palm and sole is more than 20. Senang nak ingat, okay. Siapa yang nak tengok, ambil gambar ni, okay, you can capture this, okay, capture this. I will share you I'll put this to my, apa namanya, YouTube channel lah. Nanti you can go to my YouTube channel and have a look back lah. Kalau kawan-kawan yang tak dapat share, tak dapat tengok, nanti I will share the link to my YouTube. Okay, this one everybody, especially in Putrajaya, we can ask our Dr. Akmal. Dr. Akmal, did you use this transcutaneous bilirubinometer? Okay, this one is very good because you don't need to prick the baby. Want to prick the baby? Baby, you use a transcutaneous, then you can have the measurement. What's the good about this? You know this. You only need about few seconds. Okay, few seconds. Okay. Tak ada Oh, letaklah dalam chat box Dr. Akmal tak guna chat box boleh guna chat box Dr. Akmal you can use a chat box bawah tu. Oh, ada dia kata ada. Okay, dia ada. Okay, dia kata dia ada. Dia PM me PM me. Dia kata ada dekat Putrajaya, but in our setting we don't have. We want to buy, but will our neurologist left us lah. We don't have this lah. Okay, this transcutaneous bilirubinometer, which is significant correlation with bilirubin measurement, but it's not accurate, especially you can have an overestimate or underestimate. Okay, that's why you can use your Kramer's rule together with this bilirubinometer to help you to get the level. Okay, but you need to remember one thing. When it exceed more than 12 milligram per deciliter, you need to have the blood. You need to have the blood taking. Okay, serum bilirubin, which is a gold standard to detecting and determine the level of bilirubin. Okay, blood sample should be analyzed as fast as you can because it should be shielded from the light during transport. Some of our patient, we didn't put our blood in a good condition. They have a very poor result. Okay, you need to remove phototherapy prior to sample collection. You cannot, adik-adik, you cannot take blood taking during patient having phototherapy. You need to stop the phototherapy first, then you take the blood sample. Okay, bagi tahu dengan orang A2. Orang A2 tak masuk kelas ni. Saya tak ada dengan mereka. So you can join, ask them to follow me in my YouTube. I will put in YouTube. Other thing is non-chemical photometric method. Okay, this one you no need to know lah. Okay, you need to remember one thing. Every baby, you need to visualize it by Kramer's rule. Kramer's rule. The best is if you have a transcutaneous bilirubinometer because it's time you can reduce the waiting time. We don't have a no longer have a ED to screen our patient, it's the best for us to have this. Okay, when we have this, A2 houseman have a good time. We have 20 patients, which is not necessary to it's not necessary admission, then you can discharge the patient straight away, kan? Okay, when TSB is not available, TSB is the best. Okay, when you don't have the transcutaneous bilirubinometer, is the best for you to have a TSB. Okay, another thing, transcutaneous bilirubinometer is not for you to monitor. It's a snapshot. You need to have one reading, then you need to interpret. It's not about. It's not about monitoring. You can have this bilirubinometer for the patient for just admitting. That's unmuted. Okay, I'm done for my second topic. We have a lot of other topics, which is I think about 10 topics. Okay, in this 40 minutes of time with you all, I think you slide blur ke? Tak apalah, kalau slide blur nanti boleh boleh apa namanya, boleh pergi to my YouTube channel. I will download to my YouTube channel. Okay, hopefully you can you get something from this. Okay, you can share to your friend. Okay, to your friend to make sure. Okay. Okay, to make sure they understand this one is such a crucial, important topics for housemen and doctors to know about this. Okay, so any other question to ask? 1 minute before we finish. Any other things to answer? According to PICS protocol, we have increased feeding about 15 because we already no longer in practice. No longer in practice. That's why when you have a patient, okay, when you have a patient, okay, no longer in practice. Okay lah adikku, sudah tak ada dah. Okay, less than 1 minute. Okay.